immunity is suppressed by the development of cancer cells. When we give immunotherapy, the suppressed immunology cells will overcome that and try to remount our immunity and attack the cancer cells. So this is called immunotherapy, and it is all coming up now. A combination of immunotherapy, targeted therapy along with chemotherapy has made a huge change, and we have patients in the recurrent setting, even stage 4 recurrent setting. I have patients who are doing well even 3 years after now. So that has been the development of immunotherapy, and this is what different types of chemo and targeted and immunotherapies are there. And immunotherapy is where we have right now all the newer vaccines and CAR T cells. And so these are all developments which are taking place in chemotherapeutic agents.
So that few slides to summarize the future and what we have been doing. Now what is happening is robotic surgeries are coming up in a big way. May not find much of an application as such in oral cavity, but we know that robotic surgeries make a tremendous impact on oropharynx. If you're talking about brainstem lesions or postpharyngeal filler walls or tonsillar lesions, an open surgery means a mandibulotomy, doing the resection with a lot of mobility, with swallowing, speech and all that. All this can be got rid of when you have early lesions which are resectable by a robot. Basically it's a surgeon who does it, but the robot helps in you going via the oral cavity. The patient must have a good mouth opening for that. So you are going transorally, resect lesions in the oral cavity, sitting in a console with a coffee mug, not standing, just adjust with the patient. So that is what is your robotic surgery all about. Immunotherapy, as Dr. Suresh said, is in the treatment lines now, even in neoadjuvant setup. And when we do these cases, how do we follow? We follow with clinical examinations and imaging, as you all know. But to pick up early recurrences, there are options with liquid biopsies. Liquid biopsy is nothing like doing you do a blood test, you do a blood sample and look for molecular analysis and look for these tumor antigens in that. So by that you will pick up an early recurrence. These are patients where we treat them early, then we are able to make a difference. Now we have much higher and precise radiation techniques, proton therapy to reduce the toxicity, targeted therapy is based on the molecular profiling. So these are the key takeaways for the dentists attending this forum today. Early detection saves lives, and your effort makes a big difference to the patient. And dentist is a vital member. He is the vital team member in the screening pathway. A management requires a multidisciplinary team approach. It's not a single man show that happens in oncology. Its treatment is stage specific, whether it's surgery, radiation or systemic agents, or it's a combination. It's always the teamwork which works. Rehabilitation is essential for quality of life. We do a free flap, we have done curative surgery, we have done radiation, we have done chemotherapy, the patient is on follow-up. What is the happiness to the patient if he cannot chew food? The patient will definitely be involving the dentist again. When we have put free fibula, we usually at the end of 1 year, we make sure that there is no recurrence. The patient is sent back to the dentist who has referred for the patient for putting implants, so that they will be able to do it better. Only if you do a fibula, we can do this. If you put in a PMC, that is a muscle flap, pectoralis myoperimus flap, there is no question of doing these dental implants. So all this can be possible only with the involvement of the dentist. Always follow guidelines for evidence-based care. Warm greetings from our institute, Apollo Cancer Specialty Vanagar, and this is what I meant to say: together everyone achieves more. Thank you.
So this is a previous slide where we said about feedback. So